Welcome to this conversation with Dr. Harold P. Freeman. Dr. Freeman has been a champion even before they coined the word health disparities. This forum that we have today to speak to Dr. Freeman about patient navigation is a tremendous opportunity for me to be sitting between these two giants, in my opinion. They're both giants in trying to assure access and equitable care for cancer patients. Dr. Freeman is known by most people for patient navigation, but there is a whole lot more to Dr. Freeman than patient navigation. Like I said, he's been in the trenches advocating for access to equitable healthcare. He's done it at personal level, he's done it at the national level, and this patient navigation has become a phenomenon of his own, something that started with the goodness of his heart. So it's my honor and a pleasure to welcome Dr. Harold Freeman to this forum, and also for Dr. Wayne. Thank you very much for this opportunity to work with you at this stage of my career.
The first question I have, I'm just going to jump right into it, Dr. Freeman. Why were you, as a surgeon, particularly a surgical oncologist, remotely interested in navigation?
Your question is a very good question, and it's not an easy question to answer, but I trained to be a cancer surgeon, as you have said, extensive training. I got to cutting things out. That's what I learned to do, radical surgery. I decided to come to Harlem because of my own personal background. When I became educated and learned to be a high-level surgeon, I decided I wanted to go to a Black community. It didn't have to be Harlem, but I wanted to go to a Black community to work, to see what I could do to help the people that I had lived with. And so I went there ready to cut cancer out of Harlem, because that's what I was taught to do. Cut it out, cut it out. But I couldn't do that. As skilled as I was, I couldn't cut cancer out of that poor Black community because another invasion had taken place that disallowed that invasion of poverty and racism, which displayed itself in that community. And so I had to step back and ask the question, what can I do? So I had to step away from being a surgeon while still being a surgeon and ask the questions, why are they coming in with masses that I can see with my eyes to my clinic? I took time to talk to many of those women who came in too late. And when I asked the question, why did you come in so late? Well, they said, doctor, I tried to get in before this. I went to the emergency room. That's the only thing I could go to. I don't have insurance, but essentially told me, you're in the wrong place. You need to go to the Medicaid office, which was 100 blocks south of Harlem Hospital. Get your card, come back, and don't come to the emergency room. Make an appointment to the clinic. And so the woman who was poor, who was Black, who was worried about crime in the community, who was worried about food and clothing and shelter, and had a painless lump in her breast. And for her, the process of becoming diagnosed that was being proposed to her was more painful than the painless lump. So she went back home to struggle to survive. And later, a year later, sometimes 2 years later, she come back to me finally. I'm thinking it's the first visit. No, it was not. She struggled to get in finally to me. The bottom line is, the women of Harlem taught me what to do. The women of Harlem, the poor Black women of Harlem, taught me what to do. And so the lesson there is, let us learn from the people themselves. Let us learn from them. They know, but you have to give them a chance to say it. I saw the women couldn't get in. They were coming through the emergency room. And so I decided to set up a free screening clinic at 9 a.m. every Saturday morning. And I got a $25,000 grant from the American Cancer Society to pay a clerk and a doctor from 9 to 12 every Saturday morning. And I went to the community and told them, don't go to the admitting office, come to the floor where my clinic is. Wow. Take the elevator up. Don't stop. Because they were getting stopped. It was getting stopped at the admitting office. They couldn't pay the price. So now it's a free clinic. And I began to see the women. Well, the administrator of the hospital sent somebody to talk to me and said, you can't do that. Dr. Freeman, you can't do that. I said, well, this Harlem hospital is not independent. So this hospital is under the city of New York. And so I'm going to call the city of New York that oversees the hospital and tell them what I'm trying to do and to ask them they'll help me. Talk to a woman there, vice president at the hospital corporation. She said, Dr. Freeman, you're trying to do the right thing, but you're not doing it the right way. We'll help you. When the people come to your clinic, you put this number on the chart. And by this number, they'll be in the hospital. In other words, she made my free clinic official.
Wow.
This is a Black woman, a vice president.
Wow.
So from that point on, I had a free clinic that and she said, besides, we'll give them mammography if they need it.
Wow.
We'll give them. So she solved my problem. That's the early part of my problem. People could get free examination. People began to pick up early lesions at that point from 1979 on. Finally, those people had to get treated. And so I hadn't solved that. I had solved how to get in. And so this was the origin in my mind of patient navigation.